Okay, start.
Okay, for the shift complaint, Tan Jianshuan, a 5-year-old Chinese boy, came to the emergency department with history of sudden bruising for 2 days duration. For his HOPI, according to the mother, he was apparently well and active when she suddenly noticed a bruise on his left medial part of the knee at 10 a.m. in the morning. The mother said that the child claimed,
Sharafina,
yeah,
we want you to go slowly,
oh, okay,
slowly.
okay.
So the main complaint is
The main complaint is sudden bruising for 2 days duration.
okay, sudden bruising for 2 days duration, and this is Tanjan, the name of the child.
Tan
Tanjan, is
Jianshuan.
it?
Ah, yes,
Tanjan Chen. Okay,
yes,
and he is 5 years old.
yes.
5 years old. Okay, so this case you have taken from the previous groups. It is
Uh,
not your clerking
yes, from the case right up.
because you are not in the hospital.
Yes.
Yeah, yeah, that's the thing. Yeah, that's the thing. Okay, I hope, inshallah, you get the chance to clerk by yourself. It is more useful when you clerk by yourself. Okay,
Okay.
so all of you now, you hear the main complaint, which is sudden bruising. Sudden bruising. So what will come to your mind when you see sudden bruising? What could be the problem?
Maybe some problems in the hematological system.
Hematological system. Very good. Hematological system. So what could be this problem?
Maybe ITP or um, dengue fever because of the bruising. No.
Okay. So you want to say something related to the platelet because
Mm.
platelets are important for coagulation. Without a platelet, we don't have coagulation. If there is a problem in the platelet, there is defect in the coagulation, there is bruising. So some problem in the platelet, either platelet count or platelet function. Platelet count like ITB. Tell them, Sharafina, what is ITB?
ITP, ITP is an autoimmune disease when antibody attacks thrombocytes or
No, no,
platelets.
the term. The term. What is the
Oh,
term?
immune
ITB means,
thromboplastic purpura.
okay, immune thrombocytopenia or immune thromboblasto or thrombocytopenic berbera. Immune thrombocytopenic berbera. That's ITB. So the problem may be low platelet count or platelet dysfunction. Example of platelet dysfunction. Anyone knows example of a platelet dysfunction? Platelet count may be normal, but there is dysfunction. Platelet not functioning well. Example, Glanzmann syndrome. Glanzmann. Glanzmann syndrome.
Von Willebrand.
Or we call it thrombocythemia. 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 Sthenia. Means platelet weak. Weak platelet. So the platelet count is normal, but they are not functioning. So this could be a problem. Okay. Other than the platelets, is there any other problem can lead to bruising other
Mm,
than the platelet?
deficiency of coagulation factors.
Very good. Deficiency of coagulation factors. Example of coagulation factors?
Factor 8, which can cause hemophilia. Factor
Very
9.
good. Factor A, factor 9. Yes. Factor 7. What is the difference between factor 7, factor 8, and factor 9?
Mm, I'm not sure, doctor.
Not sure. Okay. Open question. Anyone?
Intrinsic, extrinsic.
Oh,
Yes. Which one is intrinsic? Which one is extrinsic?
Factor 7, extrinsic. 8 and
Very
9,
good.
intrinsic.
Intrinsic. Very good. Very good. What is the meaning of extrinsic and intrinsic? What is the meaning? Okay, open a question. Okay, Faiz, if you hear the word intrinsic and extrinsic, how do you understand it? How do you understand it? Even if you don't know, let's say you don't know, but someone tell you that this is intrinsic, this is extrinsic. How you understand it?
If intrinsic, it happened from inside. Of if extrinsic, it happened from the outside,
From the outside.
from the
Okay,
external factors.
very good. So you know it. So you know it. Yes. So if the cause of the thrombosis comes from outside, means it is extrinsic. Like when you get wound. When you get wound, something nail or sharp knife cut your skin, then you get looking. So the sharp knife came from outside. So that is extrinsic. If intrinsic means the cause is from inside, like ischemic heart disease. So the heart is closed inside the thorax, nothing coming from outside. So the cause is entirely from the epithelium, damaged epithelium of the blood vessels, endothelium, damaged endothelium. So that's why we call it intrinsic. We call it intrinsic. Okay, so it may be a problem in the platelet, it may be a problem in the coagulation system, and it may be a problem in what else other than coagulation and the platelet?
Vasculature.
Vasculature. Example?
Example, uh, hinox, hinox choline purpura, HSP.
Inoxidation line berbera. Okay, okay.
It's like
Yeah, so problem in the connective tissue, like vasculature, for example, Henoch line berbera, or other connective tissue disorders. Yeah, because if we have problem in the connective tissue or a problem in the vasculature, then there is no control of the bleeding, and the bleeding can extend and can cause bruises. Okay, so now we need to focus on the history to know what's wrong with Tan Jan Chin. Okay.
Okay. So for the HOPI, according to the mother, he was apparently well and active when she suddenly noticed a bruise on his left middle part of the knee at 10 a.m. in the morning. The mother said there was no preceding trauma to the bruise. The bruise was described as purplish and reddish in color, a bit painful upon touch, and it was neither cold or warm. The mother claimed that the bruise started off with a swelling, but the swelling was not big and it subsided after applying cold pack and an anti-inflammatory gel to the affected area. However, on the afternoon, he brought his son to Klinik Kesihatan Bandar Kuantan because the bruise did not subside. Her child, however, refused to do the venopuncture procedure, so the full blood count was not able to be done, and his mother was advised to bring him to the hospital if there was any new bruise or bleeding episode. That evening, she noticed another bruise on Tan Zuan right leg. She decided to bring him to the emergency department in HTAA, and he was admitted to the ward. And in the ward, the mother claimed that he had bleeding of his gum. The bleeding was minimal and only occurs when he brushes his teeth. According to the mother, he had history of chicken pox a week before the presenting illness, and also during the day of the presenting illness, he has visions that has become crusted. Other than that, there was also history of dengue fever 2 weeks prior to admission, but he claimed that her son had fully recovered from it. The mother denied any episodes of fever, vomiting, diarrhea, abdominal pain, muscle pain, joint pain, and bloody stool. As for the systemic review, generally there is no fever or loss of appetite. For the skin, there are generalized chickenpox lesion with bruises at the left medial knee, right shin of the leg, and right forearm. Otherwise, there are no rashes, jaundice, or itchiness. For the cardiovascular system, no cyanosis, palpitation, syncope, orthopnea, or peripheral edema. Respiratory, no cough, difficulty in breathing, noisy breathing, or hemoptysis. GIT, no vomiting, abdominal distension, dysphagia, or odynophagia or pain. Neurological, no loss of consciousness, vision, sensory disturbance, confusion or seizures. Urinary, no hematuria, dysuria, or change in urinary habit. For musculoskeletal system, no bone pain and no muscular pain. For his past medical and surgical history, the patient has recovered from chickenpox, where it started 1 week ago. And during the presentation, the lesion has crusted. There was also history of dengue fever 2 weeks prior to admission. This is his third hospitalization. The first one was due to febrile fit when the patient was 3 years old. There is no, and the second one is due to the dengue fever. There is no congenital abnormalities known and no history of allergy, and he had never undergone any surgical intervention. For his birth history, antenatally, his mother was compliant to antenatal visit and obtained good antenatal care throughout her pregnancy. She denied taking any drugs during pregnancy and there was no problem encountered. The mother does not have any medical problem like GDM or pregnancy-induced hypertension. For intrapartum, he was delivered through spontaneous vaginal delivery at full term of gestation. However, the mother could not recall the exact amount of weeks and birth weight. The delivery process was uneventful. Postnatally, it was also uneventful. There is no history of admission into ICU, and the mother denied history of neonatal jaundice or G6PD deficiency. For immunization history, according to the mother, the patient had received immunization up to his age, and there was no adverse effect after vaccination, such as fever or rashes. For nutritional history, according to the mother, the child is currently on adult diet. He eats whatever the mother or family has prepared for him, but he is a picky eater in which he does not like to eat vegetables and fruits. For developmental history, everything is fine. Gross motor has alternating pattern when climbing stairs, can hop on one foot and was able to ride on a bicycle. Fine motor copies shape and lines, can write his own name and was able to dress and undress by himself. For speech, he was able to understand simple Malay words but could not reply. However, the child seemed to be able to speak well with her mother in Chinese language. For social skill, he was able to follow simple tasks with interest, such as exposing his stomach during physical examination. As for drug history, he is not currently on any medication and there was no history of allergy to any drug. For family and social history, both of his parents are still alive. It was a non-consanguineous marriage. The patient is the youngest child out of three siblings. The eldest sister is 9 years old and the second sister is 6 years old. The mother refused to tell both of the husband and her real age and only mentioned that it is above 30 years old. The mother the mother works as a pharmacist at Klinik Kesihatan Bandar Kuantan while the father works in a private sector. Tan Zhenjuan and his family lives in Sri Kuantan and usually during the weekdays they will stay with their grandmother while the parents are working. And her mother denied that the housing area is in a dengue prone area. Her mother also claimed that she and her husband are non-smoker, non-alcoholic, and do not have any medical illness. There is also no malignancy that runs in the family. The sister also caught dengue the same time he got it and recovered fully from it. Aside from that, there is no history of bruising or hematological disorder in the family. Okay, as for summary, in summary, my patient Tan Zhenshuan, a 5-year-old Chinese boy with no underlying disease, presented with history of bruising for 2 days duration with concomitant prior history of resolved chickenpox and dengue fever. He was not on any medication and the bruise progressively increased in number at his right leg and then to his right arm, and also the patient developed gum bleeding. This is his first admission due to the complaint and he was admitted due to the unexplained bruising without prior trauma. So, should I continue to the physical examination?
Okay. What's your comment on the summary? Okay. What do you think about her summary? So the parts of the summary you included, parts of the summary are included, but a bit prolonged, If you can make it shorter, I mean, if it is not you, it was Clark already, yeah. But if we can make the summary shorter, you know the 5 components of the summary. Number 1, the background, the name, the age, the gender, the nationality, and any underlying disease. So this one was mentioned already. She mentioned that he has no underlying disease. Then control status for any underlying disease he doesn't have. He doesn't have any asthma or epilepsy to tell about control status. You need to mention because he was previously admitted with febrile fits. So if you can insert it like previously well child, apart from one episode of febrile fits, apart from one admission at the age of 2 years due to simple febrile fits. Number 3, long-term medications. He is not on long-term medication, so no need to mention. Number 4 is the number of admission. So admitted again for the second time, or this is his second admission, was mentioned already. Then, like you mentioned, the indication, which is the progression. So this is important. The progression of the bruising. Progression of the bruising. So, okay, you can go to the physical examination.
Okay, for physical examination, generally the patient was lying supine, appearing alert and comfortable with no respiratory distress. He was pink with good hydration status and nutritional status.
No
He had no
respiratory distress. What is the importance? What is the importance of no respiratory distress?
throughout anemia due to the bleeding.
Anemia. Anemia can cause respiratory distress. Yes, yes, correct. Yes, what else? Why you want to rule out anemia?
Because he has bleeding and maybe his blood level will be low because of the bleeding.
If you have anemia and thrombocytopenia, what is the possibility? If you see patient with anemia and thrombocytopenia, can it be ITB? Cannot.
No,
Cannot be
SLE.
ITB. Why? ITB is isolated. Yes. Yes, Radha?
What if I want to see? I want to rule out
Again,
SLE.
Radha? You say
What if I want to rule out SLE?
SLE. Okay. Yes, it is possible. It is possible. SLE can cause anemia and thrombocytopenia. What is the thing more serious, which can cause anemia and thrombocytopenia and leukocytosis?
ALL.
Leukemia.
Yeah.
Yes, very good. ALL. Yes, ALL. Yes, very good. Yeah. Can leukemia cause respiratory distress? It can cause. Leukemia can cause respiratory distress because we know leukemia can involve lymph nodes, especially T cell leukemia, and can involve the mediastinum. Can involve the mediastinum. When involved the mediastinum, respiratory distress may happen. Okay? So fine, carry on.
And then he had normal body build corresponding to his age. There were generalized healed crusted skin lesion from previous chickenpox infection with bruises at medial aspect of
Okay.
the
Are these related to the condition? When you have previous viral infection, is it
yes.
related? Yes.
Yes.
Your answer is correct. How it is related?
Because preceding viral infection can be indicative of post-viral ITP.
ITB, yes, ITB. So, can you tell us the pathophysiology? Just now you were going to tell us what happened.
In ITP. In ITP,
Yeah.
there is an auto-antibody against the platelet, and then so the platelet will be destructed. So there will be low levels of platelet in the blood.
What makes the platelet destruction? Why the platelets are destructed?
Because when okay. I'm not sure, doctor.
Not sure. Anyone knows?
Doctor, maybe because of in ITP, the auto-antibody can cause intravascular lysis because the antibody can activate the complementary system.
But what causes the platelet destruction? Why the plates are destructed?
I'm
You
not
see,
sure.
I'll show you the pathophysiology on the whiteboard. Okay, 1 minute. Okay, just 1 minute. I bring a table to be able to see the whiteboard. Can you see the whiteboard now?
Yes.
Okay.
Yes,
Okay,
doctor.
fine. So you have virus. The virus has antigen. So the immune system will produce antibody. The immune system will produce antibody. So the antibody, the structure of antibody is like this. This is heavy chain, and this is light chain. So this is FC. This is FC. FC means complement binding fragment. C from complement. And this part is FAB. FAB means antigen binding fragment. Antigen binding fragment. So these antibodies will go and coat the platelet. So this is the platelet. So by mistake, the antibodies coat the platelet. Difference between self and non-self. So the antibodies come like this. So this is FC and this is FAB. So the antibodies coat the platelet. But the platelet is still not destructed. Platelet is still intact. What will make the platelet destruction is the spleen. We have the spleen here. We have splenic macrophage. The spleen has macrophage. This macrophage has receptors for FC. There are FC receptors. FC receptors. So this macrophage has FC receptors attack the platelet. The macrophage is big size. The macrophage is bigger than the platelet. The platelet is small. So this is the macrophage. This is the macrophage. Yeah. So this is FC receptor. So the macrophage will engulf the platelet. That's why if you go to treatment for chronic ITB, what is the treatment for chronic ITB? What they do for the patients with the chronic ITB?
Splenectomy.
Splenectomy. So when they make splenectomy, so no more splenic macrophage, so no more destruction of the platelet. So spleen is the cause of the platelet destruction, and especially splenic macrophage. Okay. Okay, carry on.
Okay, so next, the hands were warm at room temperature and not clammy. There was no peripheral cyanosis, finger clubbing, and the capillary refill time was less than 2 seconds. A BCG scar was noted at the left arm. On facial examination, there is no jaundice or pallor. Oral examination revealed satisfactory hygiene, no tongue coating, central cyanosis, or gum bleeding. There was no abnormal neck swelling or body edema noted. For vital signs, the patient is afebrile, normotensive, and respiratory rate is normal. Pulse rate is 104 beats per minute with good volume and regular rhythm. For anthropometric, the patient is in the normal BMI and abdominal examination. Abdomen moves with respiration. For other examination, there are no significant findings.
Wait. For abdominal examination, you need to tell us in detail. Why? Why we need abdominal examination in detail?
To look for hidden bruise, like bruise that his mother didn't notice.
No. Your differential diagnosis. What's your differential diagnosis? Yes, we look for hepatosplenomegaly because our concern is leukemia, and the leukemia causes hepatosplenomegaly. You see, if I ask one question, what is the diagnostic test of ITB? Anyone? What is the diagnostic test for ITB?
Yes, no.
There is no diagnostic test for ITB. Very good. So ITB has no diagnostic test. ITB is diagnosed by exclusion. ITB is diagnosed by exclusion. What is the prognosis of ITB? Good or poor?
Good.
Good. The prognosis of ITB is good. So ITB is a disease with good prognosis, but the problem, there is no diagnostic test to confirm 100% is ITB. So I must exclude the serious problems. On top of them is leukemia. I must exclude leukemia. So looking for hepatosplenomegaly and lymphadenopathy is very important. Must be sure patient has no lymphadenopathy and no hepatosplenomegaly. Okay? Yes?
Okay. For abdominal examination, on inspection, the abdomen moves with respiration. It was not distended. Umbilicus was centrally located and inverted. No surgical scar or dilated vein noticed on palpation. Abdomen was soft, non-tender, no guarding or rebound tenderness. There was no organomegaly. Kidney was not dilatable, and on percussion, abdomen was resonance with no shifting dullness. And on auscultation, bowel sound was present. For the other examination, there are no significant findings, and so that is all.
Did you mention the lymph nodes?
The lymph nodes. There was no lymphadenopathy noted.
Yeah. Okay. So very important. Don't forget lymphadenopathy. Don't forget hepatosplenomegaly. Yeah. Okay. So let's go to the investigations done for the patient.
Investigations. First, they did full blood count, and then there was low platelet levels, and the
How much
neutrophils
platelet?
18 gram per deciliter.
18
Gram per deciliter.
platelet, not gram.
No, it shows gram.
Typing error. So it is typing error. Yeah, platelet is not by gram. Platelet per cubic millimeter. How many platelet per cubic millimeter? What is the normal platelet count?
150.
150 to
400.
400.
150,000 to 400,000 per cubic millimeter. 150,000 to 400,000 per cubic millimeter. That's the normal platelet count. So in this patient, it is 18,000 per cubic millimeter or per microliter. Okay.
And then
Hemoglobin
hemoglobin was 13.7.
13.7. So what do you think? 13.7? Normal or low?
Normal.
Normal. So are you happy or sad?
Happy.
Happy. When you see normal hemoglobin, you become happy. Yeah, this is compatible with ITB rather than leukemia. What is the leukocyte count?
Leukocyte count. It is not shown here.
Not shown here.
Yeah.
So this means the student who clerked the case was not aware and was not focusing. So next time, when you go clerk by yourself, if you see a case like this scenario, you need to look for white cell count. Why? Why a what if? A what if why I need to see the white cell count?
To look for any infection.
Infection. What is more important, more serious? What do you think if it is a leukemia? Do you think a leukemia will have normal white cell count? Or high white cell count? High. Leukemia will have high white cell count or low white cell count because of bone marrow suppression. Yeah. It may happen that normal white cell count in leukemia, but the usual for leukemia is high white cell count or low white cell count. So that's why, like we said, ITB is diagnosed by exclusion, and first thing, it must be isolated thrombocytopenia. Isolated thrombocytopenia. Okay, then what else was done?
They did full blood picture.
Full
And
blood picture. Okay, what they
there
have
were,
seen.
hemoglobin is normal, no anisopylocytosis, and then platelet count is reduced, but no platelet clumping was seen. And then
What
they
is
did
the important thing you need to see in the peripheral blood film?
blast cell.
Blasts, because we need to look for leukemia, we need to look for blasts. Is there any comment? No blasts?
No, there's no comment about that.
Okay, so next time if you clerk by yourself, you go and ask if there is any blasts. Okay, if the peripheral blood film has no blasts, can we exclude the leukemia? We cannot. We cannot exclude the leukemia. To exclude the leukemia, you need to do bone marrow aspiration. Bone marrow aspiration. Bone marrow aspiration is the investigation which can exclude the leukemia, because the leukemia is disease of the bone marrow, problem in the bone marrow.
Okay. Next, they also did renal profile, and everything is within normal range. And also liver function test is also normal, but there is an elevation of alkaline phosphatase, and then activated partial thrombo.
How much retinal facet is? How much? How high it is?
161.
161. Okay, not very high. Okay.
And then APTT was 51.4 seconds, which shows prolonged time. And then PT was 12.4 seconds.
So ABTT is prolonged. 51.
Yes, yes.
Prolonged. Okay. BT?
PT was normal, 12.4 seconds.
Okay. Did they do bleeding time?
No, no.
Bleeding time. In fact, we need to do bleeding time. Huh? Bleeding time. Yeah, bleeding time is useful. Is useful. So now this patient has low platelet and high ABTT. Okay. So ABTT, what does it indicate? When you have high ABTT, what does it indicate?
High APTT reduce in intrinsic clotting factors.
Very good. So ABTT is for intrinsic factors. PT is for
Extrinsic.
extrinsic factors. Very good. Very good. So, and for the platelet, what indicates the platelet function or the platelet count? Bleeding time. Bleeding time. Have you done in physiology in preclinical stage bleeding time test? Have you done that? Last time in the medical school we did it in year 2. We make brick, finger brick, then we bring filter paper in the physiology lab. So we touch and remove, touch and remove. We see until there is no blood spot in the filter paper. Every time we touch, there is a blood spot. Every time until the blood spot becomes smaller, and then disappear. At the end, no blood spot. So the time when there is no blood spot, that is the bleeding time. Have you done that in the physiology? How
No.
come?
No.
How come? Huh? I am surprising. Huh? Even with that students, I asked them, they didn't do. It is one of the basic. It is one of the basic. In my university in Libya, we did it despite we don't have enough resources, but we did the bleeding time. We did it. Yeah, it indicates a platelet function because you know when you get brick, when you get thin brick like by needle, you don't need coagulation system. Platelet plug is enough because when you have coagulation, first thing is platelet plug, then the coagulation. The platelet plug is enough to stop the needle brick. So that's why we see the platelet. If we have normal count platelet and normal function platelet, we don't need coagulation for needle brick. You brick, the platelet plug will stop the bleeding. So that's why the bleeding time. Okay, so now based on this, is your patient having ITB or another problem?
IPT.
You said ITB.
Mm.
Do you agree? Radha, do you agree? ITB?
Yes, I agree.
You agree. Anyone doesn't agree? I don't agree. It is not ITB. ITB, isolated thrombocytopenia. Isolated thrombocytopenia. So if isolate thrombocytopenia, ABTT will not be elevated. It will not be elevated. If it is elevated, must be problem in the intrinsic coagulation factors. So the patient has a problem in the intrinsic. So what is his diagnosis? Is it hemophilia?
The final diagnosis was acute immune thrombocytopenic purpura post-viral infection.
No, it is wrong. Based on this data is wrong. I know maybe the hospital they diagnosed it, but they may have repeated the ABTT. because it was not very high. 51, it was not very high. I'm sure they have repeated. Maybe the student who clerked the patient didn't follow the progress, because with elevated ABTT, it is wrong. Yeah, if you come in the exam and you tell them elevated ABTT and thrombocytopenia ITB, they will say the student doesn't understand the hematology system. Yeah, it is wrong. Is it hemophilia? Why you are quiet?
Could be
Why you are quiet?
hemophilia.
Could be hemophilia. But Fahrin, okay, hemophilia causes high APTT. But does hemophilia cause low platelet? No.
No.
No, yeah. So hemophilia doesn't cause low platelet. So what's wrong with this patient? Did you hear about von Willebrand? Von Willebrand disease?
Yes.
Von Willebrand. What is von Willebrand?
Cannot agglutinate the platelet.
Cannot agglutinate the platelet. So von Willebrand is a factor which help the platelet, and help factor 8. It help factor 8 and help the platelet. It help factor 8 and help the platelet. So if von Willebrand factor is deficient, so ABTT will be high, because factor 8 will not function well, and bleeding time will be high. What about the platelet count? The platelet count may be normal in von Willebrand, normal, but the platelet will not function well. Bleeding time will be high. There is subtype of von Willebrand called platelet type von Willebrand, which has thrombocytopenia. They call it platelet type von Willebrand. So this is the difference between von Willebrand and hemophilia. Hemophilia only isolated high IBTT, only high ABTT. Von Willebrand high ABTT and high bleeding time with normal or low platelet. Normal or low platelet. So based on the investigations in front of me, it is not ITB, it is platelet type von Willebrand. But I'm sure doctors in the hospital believe that the history was compatible with ITB and ABTT is not very high, so likely they repeated coagulation profile and ABTT came out as normal. Then they diagnosed the patient as ITB. So that's why if they give you case write-up, you have to follow the patient. Don't just come in one day and take everything and take the final conclusion after that. No, you need to follow and ask the doctors. We learn when we ask. If we ask each other. Yeah, I ask this doctor. Even junior doctors, and I am senior to them, I can ask them. We learn from each other. No one knows everything, you know. Allah subhanahu wa ta'ala said, وَمَا أُوتِيتُم مِّنَ الْعِلْمِ إِلَّا قَلِيلًا. Whatever you know, whatever you become professor, you read and read, still some things you don't know. So maybe someone who is junior, go and read something you haven't read. So it is good to ask each other and take opinion of each other. So I will give you now example of coagulation profiles. I will use the whiteboard and give you some time to tell me the diagnosis. It is very important during your housemanship. When you become houseman, any patient, when they send investigations, they will ask you to analyze. So I will use the whiteboard. Okay. Okay. Do you see it now? You see the whiteboard?
Yes, sir, yes.
Yes.
Yes. Okay.
Yeah.
So patient number one has normal PT, okay, right? PT, PT, A, P, E, T, platelet, and bleeding time. Bleeding time. Patient number one, let's say has increase PT. This one normal, normal, normal. Patient number two, normal, PTT, normal, normal. Patient number three, normal, normal. Patient number four, normal, five,
Doktor. Doktor.
okay. So do you see what I have written clear?
Yes.
Yes.
Okay. Okay, let's start together. Number one. So tell me, what do you think?
Vitamin K deficiency.
It is not vitamin K deficiency. Why? Why it is not vitamin K deficiency?
Sebab bleeding time normal.
Vitamin K is needed for which factors?
2, 7, 9, 10.
2, 7, 9, 10. Very good. 2, 7, 9, 10. So 7, which pathway? Extrinsic or
Tissue
intrinsic?
factor. Extrinsic.
Extrinsic. 7, extrinsic. Will cause elevation of PT. Okay. 9, which pathway?
Intrinsic.
Intrinsic.
Intrinsic. So will cause elevation of ABTT. So if we have vitamin K deficiency, we will have high both PT and ABTT. If we have vitamin K deficiency, both will be elevated. So in this case, number one, we have only PT elevated. ABTT normal, platelet normal, bleeding time normal. So what's wrong with the patient?
Extrinsic factor.
Yeah, extrinsic factor deficiency, which is factor 7. So factor 7 deficiency. So number one is factor 7 deficiency. Okay, very good. Number two,
Hemophilia.
Hemophilia. Very good. The answer is correct. Why you said hemophilia?
Isolated
Isolated.
APTT.
Isolated APTT, which is needed for intrinsic factors. Very good. Very good. Yeah, so intrinsic factor, factor 8, hemophilia A, and factor 9, hemophilia B. Very good. Number 3.
Vitamin K.
Yes, very good. Aina Farin. Vitamin K deficiency. Is there, what is the name of the condition which happened in the newborn at age of 7 days due to vitamin K deficiency and causes bleeding? What we call that condition? There's condition presenting at age of 1 week with the bleeding due to vitamin K deficiency. What is that condition? Hemorrhagic disease of the newborn. Excuse me, I have one call from my country. I need to answer. You can look and think in the other scenarios. السلام عليكم. وعليكم السلام. خير يا سالم شو حالك؟
Korang nak tanya apa beza bleeding time dengan PTA-PTT?
Alhamdulillah.
Bleeding time tu kalau dia prolong maknanya ada problem dekat platelet.
Oh.
Ada platelet kurang ataupun platelet distraction. Dia
Oh,
boleh
maknanya
bleeding time lama tapi platelet normal.
macam platelet normal tak semestinya function dia.
Correct.
Okay. Thank you.
عندها سخونة يا سالم عندها سخونة. شو عندها؟ يسروحها فاشلة. حرارة.
Korang,
Yeah.
You?
ITP isolated platelet. No platelet. Lepas tu kiranya bleeding normal ke increase?
Increase boleh increase kan? Sepatutnya.
Increase bleeding time lah.
Sebab distraction platelet. Dia dah thrombocytopenia.
Aku rasa dia macam function. Rendah dan tak boleh function. So, bleeding dia tinggi.
Discuss.
Boleh discuss hanya sekarang.
Apa dia? APTT dengan bleeding time.
Apa yang ni? Siapa tahu?
Ni von Willebrand Von Willebrand tadi doktor kata betul tu.
Oh, ya.
Tapi platelet count boleh normal.
Platelet dia jadi rendah atau normal dan
Yang Tina punya tadi apa? Platelet type von Willebrand. Platelet type. Alright.
dia tak dengar.
Case 5. Confident. Baik.
شنو ما خدتيش مي دافيه ولا عسل ولا ليم ولا
Kalau yang nombor 5 tu DIC tak boleh ke? Sebab dia macam semua kurang.
شكله فيروس خذي عسل باري عسل وليم
Jumpa kawan lama.
مي دافيه مضاد حيوي يحلومها ولكن ما عندهاش حراره.
Kalau nombor 5 tu maknanya intrinsic dengan extrinsic factor dia dua-dua platelet count rendah.
Dia boleh jadi, betul lah boleh jadi DIC. Oh, dia boleh.
Tapi kalau yang nombor 6 tu kira dia seorang je lah, isolated lah kan, ITP lah kan? Ke tak?
Betul. Yang tinggi. So, ada
Apa dia ada ha?
bleeding tolong.
Sebab
Ke
dia
tak
thrombocytopenia kot.
Oh, faham.
Kalau macam yang 7 tu dia apa? Oh ni Glansman tu, Glansman yang doktor cakap tadi. Dia platelet normal, maknanya tapi bleeding time dia prolong.
Anyway, Glansman.
Yang doktor cakap tadi, platelet dysfunction punya problem. Ya, aku main teka je ni.
Oh, yang thrombocythemia tu eh?
Tinia,
Thrombocythemia. Thrombocythemia.
Satu
Ya.
Satu dengan dua apa dia?
Satu
Satu factor 7.
ada dia nama dia ke tak weh? Tak ada eh? Factor 7 deficiency.
Macam tak ada.
Tak ada. Yang aku cari tak ada lah.
Yeah. Oh.
Memang faktor 7 macam tu.
Nombor 2 tu hemofilia.
Okay.
Okay, sorry for the interruption. So we reached number 3. So what we call the condition in the newborn which present at 1 week?
Hemorrhagic disease of the newborn.
Very good. Hemorrhagic disease of the newborn. Yes, that's why. Have you seen new baby, newborn? Any one of you got newborn delivered?
No.
Oh.
Yeah. So when you see, if you get any newborn delivered, they'll give them vitamin K injection after birth in the thigh. Every baby, everywhere, every baby, everywhere, once born, we give vitamin K injection. We give vitamin K injection to prevent hemorrhagic disease of the newborn. Vitamin K is cheap, available everywhere, even in the most developing countries. So you are worried only from those who are born at home. If you work in Sabah or Sarawak, like if you receive one baby who was born at home, it comes to at age of 1 week with the bleeding, then you are worried. You ask whether baby was born at home or not, because if he was born at home, probably they didn't give vitamin K, and then patient may develop hemorrhagic disease of the newborn. Otherwise, if he was born in any hospital, he will receive vitamin K, very cheap, available everywhere. Number 4. What's diagnosed number 4?
Von Willebrand.
Very good. Why you said von Willebrand?
Because it has increase in APTT and
Yes.
bleeding time.
Yes.
Factor 8.
So what is the function of von Willebrand factor?
Platelet adhesion.
Help factor 8.
Yes, so platelet adhesion, like Ada said, and also help factor 8. It helps both, help factor 8 and help the platelet. So most of the time, bleeding time is normal. Most of the time, bleeding time is elevated, but the platelet count normal. There is one variant of von Willebrand disease which has thrombocytopenia. They call it platelet type von Willebrand disease. Okay, number 5. What's number 5?
DIC.
Oh, very good. DIC, correct answer. DIC. Why you said DIC?
Because PT, APTT increase and platelet decrease. It may indicate consumption of.
Yes, very good. Very good. Consumption of the platelet, consumption coagulation factor, everything is deranged. When I have DIC or DIVC, everything is deranged. Everything is abnormal. Like she said, like Aina Fari said, consumption. Consumption. Yeah. Okay, number 6.
ITP.
ITB. Very good. Number 6, ITB. Number 7.
Thromboasthenia.
Thrombocythemia. Very good. What is the name of the syndrome?
Landsman.
Landman syndrome. Very good. Yes. So now, during your housemanship, there is no worry about you. If they give you coagulation profile and ask you to analyze, you will be able to analyze. Okay, let's continue. Yes, continue your case. Yes, Sharafina.
For the management,
Uh-huh.
this patient, he was hospitalized. Hospitalization is indicated for monitoring, and then in the ward, the patient hemodynamics and vital signs are frequently recorded and monitored. There was no new development of bruise or purpura or any signs of external and internal bleedings.
Okay.
And there is also no major bleeding complications like intracranial hemorrhage or bleeding from gastrointestinal tract.
Okay, very good.
In managing this patient, IV immunoglobulin infusion was given, and then close monitoring of platelet was done. In this patient, the platelet rise slightly above 20, and then there was no significant improvement. So because of there is no new bruises that appeared, the patient was allowed to discharge, and the mother was counseled about the disease progression and was given advice to come again if there is any new symptoms or signs. And also the patient was prescribed with oral prednisolone at home. Aside from that, the patient was also given omeprazole as prophylactic drug to prevent adverse effect of prednisolone. So that is all.
Okay. Any comment about the management? What is the treatment for ITB? If they ask you on the exam, if they ask you a question, what is the treatment of ITB?
Prednisolone.
Prednisolone.
IVIG. And
IVIG. Okay, so I will accept the answer, but I will not be impressed. I will not be impressed. How to make me impressed?
Treat only if there is symptoms.
Yes?
Treat only if there is symptoms.
Very good. So ITB doesn't need treatment. If they ask you what is the treatment of ITB, no treatment. This is the answer. ITB, no treatment. No treatment. No treatment. What is the treatment of ITB?
No treatment.
No treatment. Very good. Yes, this is the answer. ITB, no treatment. Treatment only if there is bleeding. Why there is no treatment? If someone, layman or laywoman, ask this simple question. Doctor, kinaba tarawatan.
Self-limiting.
Kinaba tarawatan. Yes?
The platelet count.
Self-limiting.
Self-limiting. Yes. And the other thing, treatment will not change the natural history of the disease. You see, when you give IVIG, the platelet count will increase. If you want to make yourself happy, the platelet count will increase after IVIG, but then it will come down again. It will come down again. So recently they said there is no treatment for ITB. Treatment is not indicated. You know, 16 years back, when I just graduated, situation was different. I remember last time when we see any patient with ITB in the hospital, we become panic. Where's IVIG? Bring IVIG. Very fast, we give IVIG. Why? Because we read in Nelson, that time in Nelson old edition, we treat ITB if the platelet count less than 20. Why? To prevent intracranial bleeding. Intracranial bleeding. Something is very dangerous, can kill the patient or make them handicapped. So once we see ITB platelet count 15, we become panic. Fast, IVIG, IVIG. You know what they found? They found this intracranial bleeding is extremely rare. Extremely rare. Doesn't happen. And they found IVIG does not change the natural history of the disease. You give it, the platelet go up, like this patient, platelet went slightly 20, then it will come down again. So it will not change the natural history of the disease. So they decided not to treat ITB unless there is bleeding. If there is bleeding like gum bleeding or GIT bleeding, you give IVIG. That's it. Platelet transfusion is not indicated unless there is life-threatening bleeding, like intracranial bleeding, which is extremely rare. Extremely rare. Why bleeding is rare in ITB? Why serious bleeding is rare? Despite the platelet go down, why intracranial bleeding is extremely rare?
Coagulation factors is normal.
But you need the platelet. Still, you need the platelet. They found the platelet, the intact platelet is very strong. Very strong. Functioning very well, active. Yeah. So like, you want to fight 10 people, but not very strong. You replace them by 2 strong people. So 1 is equivalent to 5. So it will be the same force. Yeah, 2 strong people equivalent to 10 normal people. 1 is equivalent to 5. So one of them can face 5 people and can win. So that's what happened to the platelet. The intact platelet, they found them, they are strong, functioning very well. So that's why serious bleeding, intracranial bleeding is extremely rare. Extremely rare. So what is the treatment of ITB?
No treatment.
No treatment. You impress me. Yeah, when you say, yeah, it's like this. I will be impressed. Yeah. Okay. Prognosis of ITB?
Good.
Good.
Good. Okay. When we can say ITB becomes chronic? When we can say chronic ITB?
More than 6 weeks.
More than 6
months.
6
months.
6 months.
Yes, 6 months. Anam bulan. Yeah, anam bulan. More than 6 months. More than 6 months, we call it chronic ITB. Any questions? Okay, if no questions, we go to the second case.
Mine.
Okay, for the chief complaint, Amar Khalis, a 1-year, 4-month-old Malay boy, presented to the emergency department of Hospital Pekan due to unresolved fever of 2 days duration and 1 fitting episode for 2 minutes on the day of admission. For history of presenting illness, the
So
child was...
see, this case is very interesting, but I think we will not able to finish it in short time. We try to do our best because fever and fit is very important case. Very, very important. So again, you repeat again.
Amar Khalis, a 1-year, 4-months-old Malay boy, presented to emergency department Hospital Pekan due to unresolved fever of 2 days duration and 1 fitting episode for 2 minutes on the day of admission.
Okay, good. I want to stop here. Now I ask, if you are a good doctor, and I tell you this scenario, what will you do? fits and fever. What you need to do?
Treat the fever, reduce the temperature.
Treat the fever, reduce the temperature. You don't embrace me. I want you to embrace me. How to embrace me?
Check for
How to embrace them.
check
So you
for
see your
any
answer.
sign and
I give you
symptom
some
of
marks.
encephalitis or meningitis.
Yes, yes, yes. Yes, Noraina. Say again. Say again, Noraina. What you want to do? Your answer is correct. Say again.
Look for sign and symptom of meningitis and encephalitis.
Yes, very good. These are the good doctors. You see?
Look for any sign and symptom of meningitis.
Yes, very good, very good, very good. These are the good doctors. You see, the most common is the febrile fits. The most common, most of the time it is febrile fits, which is not serious and has good prognosis. But we as doctors, we have to be careful not to miss the serious problems. So the most serious problem which come with fever and fits is meningoencephalitis. Why it is serious? Because it can kill the child, or the child may not die, but will be handicapped all his life. That's why when you come to the ward later, you see many children who are bed-bound, those with cerebral palsy and multiple problems, some of them 14 years, and they are bed-bound using diapers. If you come and clerk them, the mother will tell you, some of them start crying, tell you, my son was very nice, was very handsome boy, very active until the age of 2 years. When he got fever and fit, then he became like this, which is post-meningoencephalitis. Post-meningoencephalitis. And you see, does not mean that when the child has meningoencephalitis, he will become like this. If you treat early, you save the child. The child will be normal. The child will be happy. If you ask the previous group about Yusuf, the previous group, I forgot their names. There was one subgroup. They were in the round with me. So one patient suspected to have meningoencephalitis. He has no fits, but we found the patient drowsy. So I told them, this patient suspected. Let's go and do LB very fast and treat very fast. We went very fast and did lumbar puncture, and we started our treatment. The result came out as meningitis. And because we started treatment early, the child recovered. And until now, I call his parents. His parents are very happy. The child came back to normal, recovered completely. Why? Because treatment was given early. So you can ask the previous group if you see them. The child name is Yusuf. So this is the thing. If your patient has meningitis or meningoencephalitis, and you diagnose early and treat early, you will save his life and you will make his family happy. If you delay the diagnosis, you will put him in trouble. Either he will die or he will become handicapped. So that's why number one, I must rule out meningoencephalitis. What is the diagnostic test for febrile fits? Is there any diagnostic test for febrile fits?
I think no, because it's a diagnosis of exclusion.
Diagnosis of exclusion. Very good, Awatf. Yes. Febrile fits, diagnosis of exclusion. That's why good doctors, they must exclude meningoencephalitis. So if I ask you what you need to do, so the answer, like Noraina said, you answer, I want to rule out meningoencephalitis first. Okay, carry on, Awatf.
Okay, for history of presenting illness, the child was previously well until 2 days prior to admission when he started to develop the fever. The mother noticed that the child was warm to touch, continuous, but it was not associated with chills and rigor. The mother brought him to the nearby clinic and the temperature recorded was 38 degrees Celsius. He was given syrup paracetamol. However, the fever does not subside with the prescribed medication. The fever was associated with lethargy, cough, runny nose with minimal clear water discharge. With regards of cough, it was chesty in nature and exaggerated by cold and dust. There was no pattern or relieving factor. The cough was associated with nasal flaring, noisy and fast breathing. Otherwise, there was no history of loss of appetite, loss of weight, eczema, earache or ear discharge. Around 11:15 a.m. before admission, he suddenly developed seizure. The mother who witnessed the episode noticed that there was a generalized body stiffening with uprolling of eyeballs. The mother
So generalized, this is very important. This is very important. Why it is important?
You can differentiate between simple and complex.
Very good, Awatif. We want to differentiate between simple and complex. So simple is generalized, complex is focal. Why you want to differentiate between simple and complex? Why?
Because in complex febrile seizure, there's higher risk of recurrence of seizure.
Higher risk of recurrence.
Recurrence of fitting.
What is the thing which impressed me? Noraina said just now. If there is complex, it is more possibility, higher possibility to be? Yes, meningitis or meningoencephalitis. So I have to be more careful. Still, even complex febrile fits, most of the time, it is not meningitis. Most of the time, it is not meningoencephalitis. But we have to be more careful. We want to save the children. We don't want them to be handicapped. If they have meningitis or meningoencephalitis, we want to treat them early. And the treatment is easy. The diagnosis is easy. The diagnosis is lumbar puncture. Very easy procedure. If you ask your friends in the previous group, they saw the procedure with me. Very easy. Within 1 minute, we did it. And the treatment is very easy. Treatment is very easy. IV antibiotic. IV antiviral if it is virus. It is not something magic. You don't need to open the abdomen or open the chest or cut or do general anesthesia or something wrong. It is very easy. It is cannula, IV cannula, and IV antibiotic and antiviral. So easy treatment gives good result, good outcome. Okay, carry on.
The mother claimed that there was also bluish discoloration of the mouth. During the attack, the child was unresponsive to his mother's call. There was no jerky movement of the limbs, drooling of saliva, beating of tongue, urinary or bowel incontinence. The fitting lasted about 2 minutes. After the fitting episode, the mother claimed that his child appeared weak when he regained his consciousness and began to cry. The mother then bathed the patient to cool down.
Okay, so this is also good. Something makes you happy. So it is like this. I want to rule out meningoencephalitis. I start listening. So when I hear generalized, I became happy. When I heard he cried after the episode, this is also something making me happy. Making me happy. Because what do we expect if it is meningitis or meningoencephalitis? Post-feeding, we expect prolonged post-ictal stage. The child doesn't regain consciousness. Okay, carry on.
The mother then bathed the patient to cool down the temperature and brought him to the hospital. In the emergency department, the temperature recorded was 39.4 degrees Celsius. Blood investigation was done and he was given intravenous drip. Upon further questioning, the mother claimed that this was the first episode of eating and there was no history of trauma prior to the episode, no family history of febrile fit or epilepsy, no sign of photophobia, lips making or neck stiffness. However, his sister was suffered from upper respiratory tract infection 1 week prior to the onset of the patient illness, in which she did not took any medication to relieve the fever and cough. Otherwise, there was no history of contact with travelers or water-related activity. In the ward, patient was given syrup paracetamol and antibiotic intravenously. The patient had a spike of fever of 40.5 degrees Celsius in the evening of second day of admission, but the temperature had dropped with regular paracetamol and tepid sponging. There was no more episode of fitting in the ward. For systemic review, generally there was fever but no loss of appetite or loss of weight. For head and neck examination, there is no neck stiffness. For head and neck, there was no history of neck stiffness such as crying when lying, no ear discharge, ulcer and gum bleeding noted, no bruises or head injury. For other system, it was insignificant. Except
what about cardiovascular system?
for cardiovascular, there was no history of shortness of breath, orthopnea, paroxysmal nocturnal dyspnea, no central stenosis, no scalp sweating, or no interrupted feeding.
Do you know any congenital heart disease which can cause fits?
I'm not sure, doctor.
Not sure. Okay, very good answer. There is, when you go and study congenital heart disease, there is cyanotic spill, which can happen in tetralogy of Fallot. Cyanotic spill. It can lead to fit. Okay, you still in the beginning of the course, so you can go and read by yourself. Cyanotic spills in case of tetralogy of Fallot. The child will become cyanotic, and then collapse and start fitting. Yeah. Okay. Carry on.
So for birth history, antenatally, it was uneventful. The mother did not have
You
any...
see, now here you need to take antenatal history in detail. I know you are not the one who clerked the case, but if you clerk the case, so don't say just uneventful. We need to take the events which related to the fits. Yes. So what thing can happen during a pregnancy which can cause fits in the child later? If the mother gets torch infection, the mother gets torch. Do you know what is torch? T-O-R-C-H. What's torch?
Toxoplasmosis.
Toxoplasma. O for others. R for rubella. C for cytomegalovirus. And H for herpes. What are the others? O others? HIV, varicella, and syphilis. HIV, varicella, and syphilis. That is for others. So when the mother gets torch infection, the child may get fits in the future. Why? Because torch infection can cause intracranial calcification. Intracranial calcification. Especially toxoplasma and rubella. So we need to ask about symptoms of torch in the mother. What are symptoms of torch infection in the mother?
Rashes.
Mother
will develop rash.
Rash, very good. Rash and?
Maternal fever.
Fever. Very good. Fever and skin rash. Fever and skin rash. So that's why we need to ask about history in fever and skin. So next time when you clerk yourself, antenatally ask about fever and skin rash. Was there any question about fetal movement? Fetal movement. So next time when you clerk, you ask about fetal movement. Fetal movement. Fetal movement. So fetal movement, if reduced fetal movement, it may be a sign of placental insufficiency or neuromuscular disorder. Sign of placental insufficiency or neuromuscular disorder. If increased fetal movement,
intrauterine seizures.
Yes.
Intrauterine seizures.
Very good, Sharamina. Yes. Intrauterine seizures. So don't be so happy when there is increased intrauterine movement. When there is increased fetal movement, it may be intrauterine seizures. Okay. So I give you homework. You can send WhatsApp to me if you read. Mention 2 conditions causing intrauterine seizures. Mention 2 conditions cause intrauterine seizures. So this is your homework. and I want the answer from every one of you to send to my WhatsApp.
Okay.
Okay, carry on.
Okay, intranatally, he was born full term at 38 weeks
Full
via
term. Is this related? Is this important? Yes, it is important because preterm babies may have some problems which lead them to develop fits later. What happened in the brain of the preterm baby which can make them having fits later?
kernicterus.
Kernicterus happens due to jaundice, either term or preterm. Yeah, kernicterus is due to jaundice. But in the brain of preterm baby, what will happen?
Intravascular hemorrhage.
Ventricular hemorrhage.
Intraventricular hemorrhage. Very good. Intraventricular hemorrhage. Intraventricular hemorrhage is very important. Why preterm babies they are at risk of intraventricular hemorrhage?
Because ventricle is highly vascular but poorly supported.
Because the ventricles of premature babies are highly vascular and poorly supported. Highly vascular and poorly supported. Okay. So, baby was born term, not preterm. Okay. What else you want to tell us? Did the baby cry immediately?
Sorry, doctor?
Did the baby cry after birth?
Not
Did
mentioned.
the baby cry? Did he
Not
cry
mentioned.
after birth? Not mentioned. We need to mention why. If the baby does not cry after birth, what will happen?
RDS.
Low blood supply to the brain.
Once we come out of the uterus, we need to cry. Wah, wah, first cry. Why do we need to cry after birth?
Lung expansion.
Birth asphyxia.
Wah.
Brain asphyxia. Loss oxygen. Reduce oxygen.
Yes. Very good. So we need to cry. Very good. Ada, yes, your answer is correct. We need to cry to open the lungs to get oxygen. Oxygen goes to the brain. If we don't cry, lungs not open, so no oxygen goes to the brain, then we call this birth asphyxia, which can lead to hypoxic ischemic encephalopathy. Hypoxic ischemic encephalopathy. No enough oxygen to the brain, which can lead to fits in the future. Very good. Okay, carry on.
For postnatal history, he had neonatal jaundice for 2 weeks and had a regular follow-up for about 4 times. The jaundice.
Okay, so this is what Sharafina said. So neonatal jaundice is related. Neonatal jaundice can cause kernicterus. What do you need to ask about jaundice? What treatment did he require?
Phototherapy.
Phototherapy. Did he require exchange transfusion?
Not mentioned here.
Not mentioned. Why I need to ask?
Because.
Yes. Because of the jaundice is very severe, we need to do blood exchange transfusion. So if the history tell me he required exchange transfusion, means his jaundice was severe. And why we do exchange transfusion? We want to prevent kernicterus. We don't want the baby to go to kernicterus. So if he required exchange transfusion, means his jaundice was severe, so probably the exchange transfusion was late and he developed kernicterus. But if the mother tell me like now he was in follow-up and he required only phototherapy, means it was not very high, so there was no kernicterus. There was no kernicterus. Okay, carry on.
For feeding history, he was exclusively breastfed until 6 months old. Currently, he's on formula milk. He bottle feeds every 3 to 4 hours.
Why? Why bottle feeding? Was it mentioned why?
No.
You see, the students, we teach them, but they don't follow the advice. What is the advice? What is the WHO recommendation for breastfeeding?
6 months exclusively.
Yes, exclusive breastfeeding 6 months, and then we continue breastfeeding for
2 years.
2 years.
2 years. So this is the recommendation by WHO, and before WHO, it was mentioned in
Al-Quran.
Al-Quran.
Al-Quran. It was mentioned in Al-Quran. Yes. Unfortunately, we don't follow. We don't follow our Quran, and we don't advise about our Quran. Is this condition related to breastfeeding? Is it related? It is related. Yes, it is environmental factors. We see there are genetic factors we cannot change, something genetic, but there are environmental factors. So they found febrile fits are more common in those who take formula. Epilepsy is more common in those who take formula. Meningitis and infection more common in those who take formula. So please try to take the best environmental factors. Try to take the best environmental factors. Okay? Okay, carry on.
He started weaning at 1 year old, in which he was given porridge and nestum. He also takes a dark diet with 3 regular meals per day, which consists of a half bowl of rice, chicken or fish soup, and vegetables. He's not a picky eater. For developmental history, the child has appropriate developmental milestone for his age. For gross motor, the child can walk but with support or aid. Fine motor, he can bang 2 cubes and has neat pincer grabs. For speech and language, he can say 2 to 3 words with meaning and understand faces. For social, he can take off his shoes and feed self with cup and spoon, but spills. For past medical and surgical history, this is his second hospitalization. His first hospitalization was 8 months ago for rapid breathing. He was admitted to the ward for 3 days duration. During the stay, he was given nebulizer, salbutamol, and antibiotic. He was then discharged without any complication, no previous history noted, no known medical illness, no surgical history. For drug history, he was not on any drug except for paracetamol for the fever. Otherwise, no known drug allergy or food allergy. For immunization history, immunization was complete up to his age following vaccination schedule. He has no allergic reaction following vaccination. For family history, his father is 40 years old with no medical illness. His mother is 37 years old, diagnosed with asthma, but it was well controlled. He is the 5th child out of 5 siblings. His elder sister, who is 7 years old, was also diagnosed with bronchial asthma. Otherwise, other family members was well and healthy. There was no history of epilepsy, congenital anomaly, or neurological disorder in the family. For personal and social history, his father is an ex-soldier and currently working as a security guard. He is a smoker with 8 pet years and claimed to smoke outside of the house. His mother worked as a nurse at Clinic Desa. The total income of the family is around 4,000 ringgit. They live in quarters Kerajaan Ubay with the total occupants of the house was 7 people. It has adequate basic amenities including electricity and water supply with good ventilation. He was sent to nursery during the day and there was no history of similar symptoms in other kids. For a summary, Amma, a 1 year, 4-month-old Malay boy, toddler with no known medical illness. He was doing well apart from 8 months ago when he was admitted due to respiratory disease requiring nebulization and antibiotic. This is his second admission because of unresolved fever for 2 days duration and seizures lasting for 2 minutes on the morning of admission. The fever was also associated with productive cough and runny nose. The fitting episode was characterized by generalized body stiffening and bluish discoloration of
No need. When you make summary, no need to go in deep details. Yeah. Yeah. Okay. So you can say just generalized fits for 2 minutes. Enough. That's in the summary. Okay. So the summary is good. You mentioned the background. You mentioned the previous admission. And you mentioned this is the second admission. And you showed us the indication of admission. Okay. So what's your diagnosis?
diagnosis here is simple febrile fit secondary to pneumonia.
Okay, how to impress me when I ask you what is the diagnosis? You say number 1, I want to
exclude meningoencephalitis.
Yes, very good. That's the thing which make me happy. And if I ask this question and you answer like this and you are applying for a job with me, I will accept you. Yeah, I will accept you because I will say this is safe doctor. She can work with me. If you say it is simplified fits, I will think about accepting you. Yeah. Okay, good. Okay. So we need to exclude meningoencephalitis. The points in the history are compatible with simple febrile fits. The points in the history are compatible. But now we need to go to the physical examination to be sure that it is not meningoencephalitis. Tell us physical examination.
Okay, for general examination, the child was conscious, alert, and active. The child
Aha, okay, stop. Ahmed Faiz. Child is conscious, alert, and active. Are you happy or sad? Yes,
Happy.
Faiz?
Happy.
Happy, yes. Conscious, alert, and active. So it is unlikely to be meningitis. So if you ask the previous group about Yusuf, when I was doing the round, they were with me. That time there's no MCO. We are doing the round. When I came to Yusuf, first thing mother told me that he is weak, not like before. I thought he's sleeping initially, but she said, no, he is weak. Then I tried to awake him. He is not responsive. So I became very worried. Yeah. Then we did neck stiffness. Oh, neck stiffness positive. Kernick positive. Brodzinski positive. So I stopped the round. I didn't continue the round. I told my team, we cannot continue the round. We go now. We do the lumbar puncture and we give the treatment. Then we continue the round. And this is what we did. And alhamdulillah, we did our job and it was effective. So the child recovered and came back to normal without complications. So, yes, I am happy also, like Faiz. Child is alert, conscious, so this is unlikely to be meningitis. Okay, carry on.
The child was pink, not septic looking, with no sign of respiratory distress. He
Very
has no
good.
hydration status and a normal body build. There was no dysmorphic features, no neurocutaneous stigmata, and no rashes. There was a granular
No neurocutaneous stigmata, no rashes. Which rash, which neurocutaneous stigmata did you look for?
um, cafe outlet.
Very good. Cafe au lait. We don't pronounce the T. Cafe au lait. Cafe au lait is what's feature of which condition?
Neurofibromatosis.
Very good. Neurofibromatosis. What is the mode of inheritance for neurofibromatosis?
Not sure, doctor.
Not sure. Very good. Okay. Who knows? Mode of inheritance for neurofibromatosis? Autosomal. Autosomal. Dominant. Yeah, autosomal dominant. Okay. Any other neurocutaneous stigmata other than cafe au lait?
Hypopigmented patches for tuberous sclerosis.
Very good. Hypopigmented patches. We call them ash leaf macules. Ash leaf macules for tuberous sclerosis. What is the mode of inheritance of tuberous sclerosis? Autosomal
Not sure.
dominant. Yes. Autosomal dominant. Very good. Okay. What other rush? If you see petechial rush with fits and fever, which organism? Meningococcal infection. Meningococcal. Okay, carry on.
Okay, there was a granular intact at his right dorsum of his leg without any infusion. On peripheral examination, there was no clubbing, peripheral cyanosis, or palmar erythema. BCG scar was noted on his left deltoid muscle. On examination of head and neck, the head size and shape was normal. There was no head swelling, head injury.
Head size and shape was normal. It is not enough, Awataf, in this case. I know it. You are not the one who clerked it. Did the student use this entire chart?
In the anthropometric measurement, it was mentioned about the centile.
Yeah. So what is the head circumference? Which centile?
At the 50th centile.
Yes. Very important. So head circumference is very important. Why? Why, Sharafina? Head circumference is very important.
To see development, neurological development.
Yes, very good. Because the child has hydrocephalus, he is at risk of developing fits. If the child has microcephaly, he may be at risk of brain anomaly and develop fits. So head circumference is very important. Head circumference is very important. Okay, carry on.
Okay, there was no head swelling, head injury, conjunctival failure, or scleral jaundice. Both ears reveal earwax with no sign of infection and ear discharge. The tongue was moist, tonsils were not inflamed with no exudate, and there was no central sinuses. There was no abnormal swelling, cervical lymphadenopathy, or abnormal pulsation noted on the neck. On leg examination, no bilateral ankle swelling was noted. For vital sign, blood pressure is 100/88, which is normal. Heart rate
100 over
88.
88. How to know it is normal? How do you know it is normal?
Look at the blood pressure chart.
Yeah, centile chart, blood pressure centile chart. Blood pressure is very important here. When you see child with fitting, blood pressure is very important. Anyone tell me why? Why blood pressure is very important? Ahmed Zaki, Iqbal, why blood pressure is important? Not sure. Not sure. Okay, no problem. Okay. Amir Rizwan, why blood pressure is important?
Don't know, doctor.
Not know. Very good answer. Yeah. Noor Aizatul Akmal, why blood pressure is important? I can't hear you, Noor Aizatul. I can't hear Noor Aizatul. Could you hear Noor Aizatul?
No.
We don't hear her.
I think hypertension, it can cause fit.
Very good.
Because
Yes,
low blood,
hypertension itself can cause fit. What we
low
call that
blood will go to
condition?
the brain and cause fits.
Yes, hypertensive encephalopathy. Hypertensive encephalopathy. So hypertension can cause fitting. The other thing, high blood pressure is a sign of high intracranial pressure. When you have high intracranial pressure, we have hypertension. Very good. Okay, carry on.
For heart rate, 130 beat per minute, regular rhythm and good volume. For respiratory rate, 36 breath per minute, which is normal. Temperature is 37 with is febrile, and SpO2 is 98% under room air. For anthropometric measurement, patient weight is 10.04 kg at the third centile. Height is 80 cm at the 10th centile, and head circumference was 47.5 cm at the 50th centile. For systemic examination, for central nervous system examination, for higher mental state, the child was conscious, alert, and active. Cranial nerves are grossly intact. There was no nystagmus, no unilateral ptosis, normal papillary reflex, and no facial asymmetry. For motor function, there was no abnormal posture, no muscle wasting or fasciculation. The tone was also normal. Power was 5/5 for both upper limbs and lower limbs. The reflex was present and normal. Babinski test showed downgoing of plantars. Brudzinski and Kernick signs were negative.
So that's the thing, yes. So full CNS examination we need to mention. Full CNS and development. We say neurodevelopmental examination. Must be mentioned all. Yeah. But I need you to focus on one thing in the fundus. Fundus. Was there any mention for the fundus here? For fundoscopy?
Or no.
No mention for fundoscopy. Fundoscopy is very important. Fundoscopy. So next time when you class, you need to comment about fundoscopy. Why fundoscopy is important? Who will answer? Open question. Yes, why fundoscopy important? Anyone knows? If there is double edema, what does that mean?
Raise ICP.
Very good. Very good, Faiz. Yes. Raised ICB. Raised intracranial pressure. If there is babillidema. Okay. If there is retinal hemorrhage, if there is retinal hemorrhage, yes.
Hypertension, hypertensive.
Not hypertension. If there is retinal hemorrhage, you need to rule out shaking baby syndrome, child physical abuse, shaking the baby. Shaking the baby. So let's summarize 5 parts, very important. You see my hand, 5. When you do physical examination for a patient with fits, don't forget 5. Other than 5, you need to look for focus of infection. Like in this child, he has pneumonia. So we must examine the ears, the throat, the lungs. We need to look for infection. So out of this 5, I want to look for focus of infection. What are these 5? Let's do them together. Number 1, full neurodevelopmental examination. Full neurodevelopmental. So like she did, full neurological examination, everything, the cranial nerves, meningeal sinus, developmental assessment. Number 2, skin. Like she mentioned, look for neurocutaneous stigmata and petechial rash. Number 3, blood pressure. Blood pressure, like we mentioned for hypertensive encephalopathy or signs of high intracranial pressure. Number 4, head circumference. We shouldn't forget head circumference. And number 5, fundoscopy. Fundoscopy. So again, out of this 5, I need to look for focus of infection. Throat, ears, lungs, anywhere. Then 5. Number 1, full neuro developmental examination. Number 2, skin examination. Number 3,
Blood pressure.
blood pressure. Number 4,
Head circumference.
head circumference. Number 5,
Fundoscopy.
fundoscopy. So if you mention that, you take the full mark in the exam. Okay? Carry on.
For respiratory examination, the patient was not in respiratory distress, no stridor or wheezing was heard. On inspection of the chest moved with respiration, there was no chest deformity and chest recession, no surgical scar or dilated vein noted. On palpation, trachea was centrally located, apex beak was felt at 4th intercostal space, at left midclavicular line with normal character, tactile vocal parameters were normal and equal for both sides. On percussion, no change in dullness was felt. On auscultation, vesicular breath sound was heard on both lungs without any added sound, such as rhonchi and crepitation. Vocal resonance was normal.
So why they say the pneumonia? No signs of pneumonia.
But there is finding in chest X-ray. I think so.
I see. So they based on the X-ray, they diagnosed pneumonia based on the X-ray.
Yes.
I see. Okay.
Okay, for other systems, there was no finding.
Okay. So final diagnosis, you said it is first episode of simple febrile fits, secondary to pneumonia. Is it like this?
Yes.
Must say first episode, first episode, because we don't admit second episode or third episode when we know we don't admit the patient. Still a lot of discussion, but I cannot say it all now. You can go and read by yourself, and maybe if we have another class, we can discuss about criteria, how to differentiate between simple and complex, and how to manage the patient during the fitting episode. Go and read how to manage the patient during the fitting episode, the first aid management, and how to advise the parentis, how to counsel them, how to do lumbar puncture if it is indicated. So all that you can go and read, and you can discuss with me. You can ask me by WhatsApp, no problem. I only need to ask one thing and discuss one thing at the end. If I ask you what investigation is needed, and I want you to impress me. If I ask you what investigations you will do for this child, so there is one answer correct, but there is answer impressing. Yeah, child coming with fever and fits. What investigations you will do? What blood test you will do? Yeah. Okay, the question is open.
Blood glucose.
Blood glucose. This is the embarrassing answer. This is the embarrassing answer. The normal answer would just give mark, normal mark, 50%, full blood count. Yeah, many students, they say full blood count, full blood count. No, it is not full blood count. One child coming with fitting. So I want something very serious, something correctable. Blood sugar, hypoglycemia can cause fitting. Hypoglycemia can cause fitting. And very easy. One brick, blood sugar. You can see. You can see the result. And if hypoglycemia, very easy to correct. Give glucose. Third line, give glucose. So very easy to get the result. Very important. Very effective. If the patient continue fitting while he's hypoglycemic, his brain will be damaged and correctable. So you will impress me. Number one, blood sugar. If you say full blood count, you will not impress me. I will not say wrong. I will not say wrong, but you will not impress me. I'll give you 50%. If you say blood sugar, you will come to 90%. You are in the area of distinction. Okay. Number two, what thing impressed me more? Number two after blood sugar? Yes? Yes? Siti Noraina?
Electrolytes.
Electrolytes. Very good. Which one? If I ask you to choose one, sodium, potassium, calcium, which one you'll choose?
Potassium.
Potassium.
No, not potassium.
Calcium.
Calcium. Very good. Calcium. So if you say sugar, number one, you impress me. If number two, you say electrolytes, I quite happy. But if you say calcium, you go for distinction. Yeah. Sugar, calcium. Yeah, calcium, very important. Yeah. Then sodium, potassium, renal function. Then you can come for the full blood count. Full blood count. After that, you can go for the urine analysis because you know UTI can present with febrile fits. And after that, I discuss LB, whether it is indicated or not. I consider LB if it is indicated. So maybe the examiner will ask you, when will you do LB? You say, I will do LB if I suspect meningitis. So, will you do LB in this patient, Awatif?
No,
No, your answer is correct. Why you will not do LB?
there's no sign of meningitis such as.
Yes, very good. Will you admit this child to the hospital or you send home?
Admit at first episode.
Yes, very good. Why you want to admit at first episode?
To rule out other pathology other than.
Yes, very good. Yes. So first episode must be admitted. After that, when we counsel the parentis, if it happens again, we don't need to admit the patient. So I will stop at this moment. Again, go and read how to differentiate. There is nine criteria how to differentiate between simple and complex febrile fits. Go and read how to do in the first aid management for a child with fits, either febrile or not febrile, and how to do the lumbar puncture. Lumbar puncture, I think we have procedures class tomorrow. Is it? So you are included, huh? All the group, I think.
Yes.
Yes.
Okay. So you will have tomorrow. It is better to go and read. So tomorrow when I ask about the lumbar puncture, you will be able to answer. Okay. Any questions at the moment? No questions. Okay. So if no questions, we will end our class. I see you tomorrow, inshallah. I hear Adhan Maghrib, and I'm happy because I'm fasting, so I go and book up Wasa.
Okay. Thank you, Doctor.
Thank you, Doctor.
Thank you. Thank you. Thank you.
Selamat
Goodbye.
berbuka.
Doktor.
Thank you.